Director of the Bayer Foundation. I would like to welcome you all to our session, Inclusive Innovation, Building and Sustaining Public Health Infrastructure through Digital Global Goods. At the Bayer Foundation, we are committed to work towards our mission, which is health for all and hunger for none. And for quite some time, we've been looking for a way to support and scale high impact ecosystems in health and also agriculture through our Social Innovation Ecosystem Fund. And to achieve our goal, the partnership with MEDIC and PASS is a perfect fit, as you will hear soon during this session. We are investing in this ecosystem not only so we can support the development of a public good platform, but also and especially to support local African developers. Because for us, it is crucial for the sustainability of our engagement that all development in Africa is from Africans for Africans. But enough said from my side. I hope I made you a bit curious. So now let me invite you to an exciting journey where you will learn how important a public good platform is for the African health system in order to serve patients, communities, community health workers, NGOs, and governments today and also in the future. And with this, I'd like to hand over to Wambui Kinya, Director EMEA for Elephant Ventures, who will lead you through the next 60 minutes. So welcome and thanks, Wambui, for taking us through the day.
Thank you, Monica, and indeed an exciting afternoon. Greetings and welcome. My name is Wambui Kinya, as Monica has said. I'm currently the Regional Managing Director of Elephant Ventures, a global innovation services company that has honed 18 years of delivering ideas to market traction into what we call dependable innovation. I am also proudly a newly appointed board member to MEDIC, and it is my distinct pleasure to moderate this conversation today from Nairobi, Kenya. So often with virtual sessions like this, it is hard to meet one another. So in an attempt to get a better sense of who is here today, it would be great for you to post your name, organization, and the city you are logged in from. And you can do this in the chat feature and post to everyone. Okay, let's get started as we have a very packed agenda. African countries are now more so poised to advance the tools built in the urgency of the pandemic response into key foundational pillars of the health system. In doing so, it is important to ensure that technology can achieve several things: scale, prove impact, and most critically, as Monica has mentioned, be locally implemented, owned, and sustained. We have an esteemed panel today who will share from their experiences this session's objectives to understanding elements required when enabling an inclusive innovation environment, highlighting how these elements support and sustain robust digital health ecosystems, and the importance and timeliness to increase the visibility and profile of local entrepreneurs to build stronger digital economies and accelerate the wide-scale adoption of global goods. So the way we will run today is we will start with a keynote address, which I'm excited to hear, followed by a panel discussion, following on some of the topics that have been raised. Our keynote address, if we can get to the next slide, will be presented by Dr. Joseph Sitene, Acting Directorate of M&E, Health Informatics and Research with the Ministry of Health in the Republic of Kenya. Dr. Sitene, it is our pleasure to have you update us on the approach in Kenya. Over to you.
Thank you very much, Wambui, and thank you very much, everybody. It's really a great pleasure for me to have been given this great honor to give the keynote address. I feel so much humbled. I don't even know whether I will meet the expectations to provide that keynote address. But yes, here we are. And I think the choice is based on the fact that Kenya has moved to this space of digitization. So let's quickly go to the yes. This slide is actually a demonstration that for all of us who are here, and maybe others who may not be here, we do appreciate the fact that data has become the new oil, to an extent that many people are starting to guard this new oil in a manner that is commensurate to what they think is the importance, the extent to which this data goes And yet we cannot do innovation without data, because that is the foundation, that is the stone that sometimes we neglect. And then at the end of it all, we come to the full realization that without data, we cannot advance our innovations beyond a particular level. So for us to be able to move together without leaving anyone behind, we must be able to understand the old African adage that if you want to go fast, you go alone. But if you want to go far, you have to go with others. Next slide. So from the Kenyan perspective and where I sit, the Ministry of Health and the government of Kenya by extension has come up with a great vision to develop a comprehensive integrated digital health information system. This comprehensive digital health information system is based on the fact that we have the law that has been passed by Parliament, and that law is the Health Act 2017 that specifically addresses the question of the digitization of health information system. But beyond this, you'll be seeing the landscape has even changed a little bit better. So for us, that is the vision. We want to have a comprehensive integrated digital health information system. As to how we will go this path, all of us have a role to play, particularly those who are working in Kenya and the partners that we rely upon to support us in this great work that we have to do. So next slide, and I'll try to be a bit fast. Next slide, please. Yes, so several things have happened in this country that have led us to sometimes land in problems with our data. So we have had to have so many parallel and independent systems, which are mainly disease specific or project specific. And most of those types of information systems that have been in place are also M&E systems. The type of the vision that we have from the ministry is to have a patient-centric health information system, a little bit away from the M&E systems, and consequently, eventually, to have the system to provide the M&E, to meet the M&E requirements. So for us to be able to effectively roll out the plan that we have, we conducted a landscape assessment in 2018, and we found that in a small country like ours, with only 50 million people, we had a total of 75 community health information systems. That is quite a lot. All of them disparate, none speaking to the other one. And of course, with the attendant risk of losing the data eventually, particularly when the partners pull out, or in terms of sustainability, when that is not available, payment for the licensure and things of that kind. Only 59 out of the 75 are in use. Still parallel and standalone. But the most important thing about them is the fact that when it comes to sustainability, you can see that almost 80% are supported by partners. And this is now where the big issue arises, because partners come and partners also go when the project goes. And sometimes they go not just with the system, but they also go with the data. 8% is supported by the county governments, pretty low. 4% by the national government, and quite a number of them are also unsupported. And in some instances, some of these health information systems are actually dead. This is what now led this conversation that the country needs its own system that it can be able to sustain, monitor, and use for the benefit of Kenyans and Kenya at large. Next slide. And of course, we do appreciate the importance of the parallel systems. Of course, with this and coordinated digitization, the consequences are multiple, some of which I've already mentioned, that there is existence of multiple and disparate systems, but more importantly, with limited capacity to exchange health information in a meaningful manner. That is where the rubber meets the road. Exchange of information in a meaningful manner so that the next system can be able either to aggregate or use it to make decisions out of it. This has led to unsustainable systems, as I said, most of which are M&E systems, with the risk of vendor lock-in, loss of vital data, and that is very critical, with disparate systems that are standalone, therefore meaning that we are unable to use the data for decision making because we are unable to aggregate this data at the required levels so that we can be having a more holistic picture. Of course, this has led to poor accountability of resources which have been injected. sometimes loss of these resources, misuse of data. And of course, in the case of Kenya, we do not have any remote healthcare support. And the digital platform that is being developed should also be able to provide this remote care, because as we move ahead, it is becoming increasingly important that some of the conditions can even be managed right at home, as opposed to people moving to the health facilities. Next slide. So the Kenyan government has had to do several things to put the landscape to be in the good, to levelize the landscape, which runs from the vision, from the Kenyan Constitution, and I would like to flag out two laws that have been passed: the Health Act 2017, which forms the basis of our vision, and the Data Protection Act, which clearly stipulates as to how the data should be collected, stored, and used. And of course, the MOH policy environment has been changing quite fast. And again, we have the e-health bill. Now that we are moving away from paper-based systems towards digitization, then we need to address the gaps that have come out. And of course, there are these emerging issues. The President of Kenya has pronounced himself on the need to roll out universal health coverage to cover the whole country. That was pronounced in December of last year, 2021. And of course, this wake-up call from SARS-CoV-2. Next slide. So to go specifically into the legal environment, which is very critical, as I said, this forms the basis of the vision. That under Section 5, the Ministry of Health shall facilitate the health information system establishment and maintenance. So the issues of sustainability now becomes the work of the government. And of course, the development or the establishment of an integrated, comprehensive health information management system. And this is where we come from. We are powered by this law to be able to actualize our vision. And of course, to compound this and to make it even much more grounded is the Data Protection Act, which sets the conditions for transference of data, if at all, outside the country, and also the ownership of the data is now clearly defined in the Data Protection Act. Next. So looking at the Kenya's community health system, the aim of the health system, the community health system, is actually to build demand for services at the community level by improving community awareness and health-seeking behaviors. Suffice to put it that the type of the health system that is being rolled out in Kenya is hinged around level 4, which is the sub-county hospitals, and that forms the hub of the primary healthcare system. Below that, we are dealing with the spokes that feed into the hub. And below the hub, which is the county referral, the sub-county hospital, we are more inclined towards preventive and promotive services. When you hit level 4 in the service delivery, you start to move into curative services. And level 5, 6 are all mainly geared towards curative services. So going back to the community, the primary healthcare, one community health unit covers a population of about 5,000 people with a households of about 1,000 per community health unit, averaging about 5 persons per one household. And one community health volunteer serves about 100 households. This is where the trick starts to come. One, these people are volunteers. That's number one. So they are not on anybody's payroll, and they do this out of goodwill. Most people will not do it, including myself. And I guess some of the people also seated with me. They will not put their effort to serve 100 households at no cost when we cannot put food on our table. In addition to that, sometimes the information systems that go to the community do not recognize that this person is already overloaded and overworked, because we keep adding things, sometimes parallel different systems, to overload this person even more. And of course, we are talking about a population of almost 50 million people. So we have about 9,500 community health units with approximately 12 million households. So in terms of coverage, we are now dealing with about 83% coverage for community health units. So the government has really done a lot to expand coverage. And we are expecting that the CHVs who have been enrolled, and in this case, 94%, we are going to serve the community, the communities where they come from in a much more better way. But of course, we have to bear in mind that because they are volunteers, there is, and that risk exists, that the turnover of these community health volunteers is very, very high. Next slide. So we are talking about building an inclusive digital health ecosystem. So even as we think about working at the community level, we should realize that it is a whole spectrum, not just at the community, but it goes beyond the community. It goes much higher because it includes the health facilities. As I said, in Kenyan system, it is hinged around level 4 for the primary health care. And then above that, we go to level 5, which is the county referral hospital, and level 6, which is the national referral hospital. And those particular levels of service delivery are heavily hinged towards curative services, as opposed to prevention, which is actually being rolled out in the primary healthcare services within the country. In addition to that, and to improve services even much more, we should also be considering the role of telehealth, particularly at the community health, at the community level, and telemedicine, where there is that need to support the primary healthcare facilities. Instead of transferring the patient to go up the care system, we actually have the patient retained and they are getting the services that they require. And moreover, the country is also exploring that possibility of transferring the specimen as opposed to the individual himself moving. Next slide. So then the community health policy comes into play to lay the foundation. Under specifically Objective 4, this one focuses on community health information systems. That of course CHVs and CHAS, these are community health assistants, take the lead in household visitation, data collection and monitoring. And they also are capacitated to do basic analytics of data, really very basic. You have to bear in mind that these people are not healthcare workers of any shade. They have not gone to any school, of medical schools to be able to learn, but they are able to teach them because these are literate people to do basic analytics that can be used to make some information. They summarize and forward the data that they have collected to the sub-county HRIO for uploading into the DHIS. Now, this is where, again, the data starts to be aggregated at a little bit higher level. But looking forward, we are actually moving away from this type of data collection, where we are dealing with service statistics. We want to move to patient-level data. And that is the system that the government is rolling out through the electronic community health information system to be able to capture patient-level data and then store it in a safe place, transmit it in a secure manner that meets the requirements of the law. And then after that, to be able to push the data, or rather pull the data, whichever that is applicable, for the service statistics as an endpoint, where now the visualization and analytics can be done. So we do have now at the moment nationally accredited applications which have been deployed to ensure quality of community health data collection and reporting meets the requirements of this policy. Next slide. In addition to this policy, we which is been rolled out, as you can see, it runs from 2020 to 2030. It has been aligned to what we call the Vision 2030. And the Vision 2030 shows us the vision of where Kenya needs to be by the year 2030. So that alignment is on purpose. In addition, it is also aligned to the sector documents. In this case, I'm talking about the National Health Sector Strategic and Investment Plan, so that progressively we can be able to achieve and to move towards where we want to be as a nation by the year 2030. I submit, Chair.
Thank you, Dr. Sitane. It's great to hear not only the progress that has been made, but certainly the focus, the political will, the environment in which you are now continuing to build patient-centric health system. So thank you very much. We'll now move to the panel, and I will introduce our panelists in the order in which they will now share a brief summary of their experiences and a point of view before we get into the actual Q&A. We will begin with Kanishka Katara, Chief Digital Health Officer of Living Goods, Dr. Krishna Jaffa, CEO Medic, Tara Herrick, Senior Market Analytics Officer from PATH. I will now submit to Kanishka. Thank you.
Thanks, Vambu. Okay, cool. Here's the slide. Well, while the slide comes up, first of all, kudos to the organizers and every stakeholder involved with this event. It's been such a honor to be a part of this panel with such elite panelists who everyone has been such a leader in their own way to improve health access and equity amongst the community. Thank you for inviting me and having me here. What I'm going to be talking about is, what Living Goods does as part of our programs and what we totally believe in. But before I come to this, what you see on the slide as the desk approach, let me just draw back to what Dr. Sitanai mentioned, that data is the new oil. And in fact, it is the new oil. We need data for every aspect of our lives today, whether individually or as a group or as an organization. And data and digital has become such an important part of what we do, professionally or personally. What has been very encouraging for someone like me to see is the increased adoption of data and digital in the community health space to improve service delivery, to improve outreach to the beneficiaries, and at the end of the day, enable the key stakeholders, the community health workers, with data and digital. At the same time, we also need to acknowledge, and I'm sure all of us acknowledge, that the CSW space is a very nuanced space compared to the world we live in. They need more holistic interventions so that they can use the data and digital elements in the right way and really benefit from such interventions. Which is where, as Living Goods, we believe that the desk framework, can we move to the next slide, please? The desk framework, the desk approach, which we have been piloting across all our programs, is really effective and is the right approach to actually introduce data and digital and make that change at the ground level. Can we move to the next slide, please? Yes, thank you. A very quick introduction of what DESK is. DESK is digitally equipped, supervised, and compensated CSWs. We believe that digitally enabled CSWs who are equipped with the right tools, the digital tools, to cater to their beneficiaries, to provide service delivery, to work as a job aid for them. They need to be equipped with the essential medicines and other resources, along with training. They need to be supervised so that it increases accountability at the local level through supervisors or managers at the primary healthcare stage. And also they need to be compensated because as Dr. Sitanai also touched upon this, compensation is important to keep the motivation up, to effectively empower the CSW so that they can continue doing what they are doing. We also believe that this initiative of DESK, and we have seen it across all our programs, digital tools and data for decision making are really important engines of our strategy. In fact, if you look at the DESK framework, digital is the first element and it enables all the other aspects of the DESK approach. We believe that DESK is designed to improve the performance of CSWs, ensuring that they are incentivized and able to deliver high quality healthcare at low cost. And we have been working with Government of Kenya in our learning sites, piloting these programs, and of course in government-led sites also, to implement this and see the benefits of this. There has been enough evidence on the ground to show that this is the right approach and look at it from a holistic perspective. Next slide, please. In addition to the DESK approach, we also believe that it has to be a cross-cutting enabler, and which is where we look at data, digital, and the disruptive innovations in the digital world to be the right anchor to focus upon. As part of this, we believe that strengthening our own and others' capabilities to use digital tools and data to inform decision making at every level is very essential. We continue to be software agnostic as part of this approach, and supporting the government to design and roll out digitization solutions which work at the ground we can easily pick up innovations from other sectors and believe that these are the right innovations. But as I said, the challenges of public health and community health are very nuanced. So we need to understand that what will work on the ground, even if smaller gains are made, that is still a step forward while keeping the larger objective in place. And which is where this enabler really helps us. And we believe in this enabler, looking at what can unlock impact for communities. How do we enable the desk approach? How do we manage for better results? Creating innovation opportunities and achieving the robust and resilient community health systems as an outcome of this cross-cutting enabler of data, digital innovations. Can we move to the next slide, please? Yes, and I mean, Dr. Sitina has given such a wonderful overview of the program and the work which government is doing. I don't really want to spend much time on this, but I would want to add a bit on this, that we work very closely with the governments as Living Goods and the partners involved in the ecosystem with a focus to strengthen the national community health systems. And of course, ensuring CHWs are effectively compensated, supervised, and equipped. The EACH's initiative specifically is an extension of our learnings and experiences. This has been designed to address the challenges related to information availability, quality, acceptability, utilization, efficiency, cost, and accountability at the ground level. It will ensure that household health data collected at the community level is linked to upper levels of the health ecosystem, or rather, I should say the e-health ecosystem. The work which government of Kenya is leading will lead to a very modernized and a larger infrastructure being generated over a period of time. This will also help in integrating data from different sources, including service delivery, will help in surveillance going forward, surveys to enable data-driven decision-making, and will be key in ensuring an effective early warning system at the community level. As Living Goods, we totally believe in the potential of this program EACH's, and which will really lead, and we believe that it will lead to a more resilient and strengthened health system in Kenya. This will, on all the likelihood, this will also serve as an exemplar example for other countries to follow and look at and learn from, and then benefit from this program. We are proud to be associated with Government of Kenya in this important initiative. And as I mentioned earlier, the pilots we have undertaken, both in our learning sites, as well as government-led sites, where we are working with the government officials, have given enough evidence that the DESK framework works and data and digital is the right strategy. I know I'm just about on time, but I would want to close by saying that we have been the early adopters of data and digital and introducing them at the community health space. And we believe that this is the right way forward. And it's so encouraging to see that almost everyone is on board in this journey now. I know Krishna is going to follow me, and she has just taken over the lead in MEDIC. But MEDIC and LG have been partnering together in this journey. And with this, I'll just hand over to Krishna. Maybe Krishna can also throw some light on how MEDIC is planning to support the government in this journey. But yeah, thank you.
Thank you, Kanishk, and thank you so much for this opportunity. Thank you, Wambui, for the kind introduction, and Dr. Sitine for getting us started with such good energy, and more so for your deep commitment and leadership toward achieving universal health coverage for all Kenyans. Today, I'm going to briefly share MEDIC's journey in digital health for community health systems, building upon two key foundations: human-centered design to empower community health workers and deepening local ownership via community of users. If you can go to yeah, that's great, thank you. The current gaps that we have in healthcare drive millions of annual deaths and incalculable morbidity, and community health systems are often the least resourced, as we know. Under the leadership of Ministries of Health and in partnership with Living Goods and other community health implementers, we have seen firsthand the sound application of human-centered design principles to prototype, test, validate, and refine apps built on an open source framework can in fact improve the leverage, quality, equity, and cost effectiveness of care. As you know, most community health workers are female. They are often unpaid, poorly supported, and not seen as part of the formal health system. As Dr. Sitine shared, digital health has emerged as a very powerful opportunity to facilitate training and supportive supervision of health workers in the low resource and last mile settings in which they work. Over and over, we hear from CHWs of the empowerment fostered by such training and support, and we believe this investment is well worth it. In Mali, we partnered with the Ministry of Health and MUSO to combine MUSO's proactive community case management, or PRO-CCM approach, with digitally enabled CHW activity tracking and supportive supervision. And together, we were able to increase the number of CHW home visits, the timeliness, and the quality of CHW care. In Zimbabwe, we partnered with the Ministry of Health and Child Welfare and with ITEC to gather evidence that two-way texting for voluntary medical male circumcision clients reduced unnecessary follow-up visits and increased timely detection of complications and adverse events. This also improved cost effectiveness. We also advocate, along with the Community Health Impact Coalition and the World Health Organization, for ongoing professionalization, remuneration, and advancement opportunities among CHWs. Next slide, please. Despite all of this progress, few digital health interventions have achieved scale and sustained impact, resulting in today's highly fragmented digital health landscape. Vertical and shorter-term funding cycles, cost barriers, and insufficient investment in true country ownership are some of the reasons for these market failures. And we'll hear from Tara next about some of the other reasons. When done right, digital public goods offer low and middle income countries an affordable, scalable pathway to local ownership by supporting adaptation and deployment by a community of local technical organizations. These organizations fundamentally have a different stake in local deployments compared to global organizations and nurture long-term working relationships in their countries or regions. Next, considering efficiency and the urgent need for shared infrastructure in our space, this was when MEDIC made a strategic decision to move our tools, knowledge, and skills into the public domain. A defining feature of this move was to see if we could set up a successful digital public good and have a viable and vibrant community of users who adapt and use the technology. In 2018, MEDIC and our partners launched the Community Health Toolkit as an open source resource for community health. The CHT, as it is widely known, includes free open source software frameworks and apps, resources to help build and use the tools, and a public forum for collaboration and support. If you aren't already a member, we warmly welcome you. Our goal is a shared toolkit that will create a world-class and open source option for community health systems, reduce technical redundancy, improve the quality of health systems, and provide a platform for true local ownership, creative extension, reuse, integration, and research without needing to go and ask someone. We emphasize global standards and interoperability in our work. Together with our partners, MEDIC is growing a community of digital health practitioners, primary app builders, and implementers in country. Our main focus is to enable them to harness the toolkit and build, deploy, and scale CHT apps that support millions of caring activities globally in the communities that most need them. We also want to encourage this community to give back in a number of ways. And the opportunity we have before us is to prove that a truly global and fully open public good can keep scaling to address a substantial portion of the total unmet need for advanced community health information systems. With that, thank you so much for your attention, and I'm going to hand it over to Tara.
Thank you so much for inviting me here today and for this opportunity. It's been very interesting to hear all of the wonderful presentations. My name is Tara Herrick. I'm a senior officer at Path and Digital Square. If you can move to the next slide. Thank you. Today, I'll be talking about 3 lessons that we have learned when scaling inclusive innovations. And the first is that the context is very important. And we've heard this a lot from the other presentations, but one needs to carefully think about user requirements when developing new digital solutions. We undertook an exercise to segment the market into 5 digital health maturity levels, and it's shown on the map on this slide. This market segmentation is in the public domain, and we have a source for this on the bottom. We utilized World Economic Forum network readiness indicators based on political and regulatory environment, infrastructure, as well as digital literacy and skills. To provide a bit of context, a lower digital maturity environment, they have 2G infrastructure, variable electricity, and a lower skilled workforce. In contrast, a higher digital maturity market, these countries have 3G infrastructure, reliable electricity, and a digitally literate workforce. In addition, the policies also differ between these markets, with lower maturity markets having few policies or policies not in place at all, whereas the higher digital maturity markets have policies, digital policies that are actually enforced. Most countries in the world are in digital health maturity markets 2 and 3. And as mentioned, we see limited examples of products that have scaled in these markets. Next slide. We use this market segmentation model to think about end user requirements. We undertook an exercise where we spoke with software developers and we asked them where they worked and what product features their products have and their end users demand. And we see that there's some pretty striking differences in terms of product requirements. In the lower digital health maturity markets, we heard that offline functionality or the ability to be used without an internet, SMS messaging, and deduplication and compression were very important. However, in contrast, in high digital health maturity markets, we heard that artificial intelligence and machine learning was an important feature. In addition, often in those markets, software as a service is critical for the business model and needs to be incorporated into the tool. Cloud-based is something that varies by country and also needs to be thought of with careful consideration. But really understanding the context and the product requirements is a first step. Next slide. We also have heard that, we also know that it's extremely important to engage with the end user directly. And we've already heard a lot about this from the other panelists today, so I'm not going to go into detail. However, wanted to share a few themes of what we've seen. First is that often software is for donor reporting and rather than clinical workforce flows. So healthcare providers do not always see direct benefits for using and engaging with digital tools. The second is that the data collection efforts are often duplicated, and this creates strains on healthcare workers' very valuable time. Healthcare workers can enter data into a paper-based ledger at times, as well as a digital system, or at sometimes more than one digital system, which can be very problematic. And then third, given challenges with interoperability, healthcare providers do not always see the holistic patient history. And this is something that's desired and extremely important for health impact. So these are a few things that we've heard from end users, but it's very important and to engage with end users directly in order to make sure that the digital solutions meet their needs. Next slide. Lastly, I want to highlight the importance of thinking about plans for sustainability very early in the process. We've found in our work that operating costs, in particular for digital health, are often not funded or underfunded, and this creates challenges for sustainability. So Digital Square currently has efforts underway to really provide more transparency on the total cost of ownership for digital solutions, but new business models are needed to fund operating costs. In addition, we believe it's very important, given the fragmented nature of the ecosystem, for digital providers to really highlight what their unique value proposition is relative to the competition, and to make that known as part of their business plan when presenting their specific tools for funding. These elements will be really important for creating sustainable solutions. So with that, I will close and hand it back over to Wambui to open it up for questions. Thank you so much.
Thank you, Tara, and thank you to all the panelists. Tara, perhaps you can start off our panel Q&A. So you've touched on the market dynamic forces that enable or prohibit the building of digital public goods. Understanding this, how would you prioritize which of these forces are perhaps more critical to accelerate the success of these builds?
Thank you so much for the question. It's a great question. There are indeed some interesting market forces that are at play when building digital public goods. You know, as mentioned, there are clear product requirements and end user needs between low and high digital maturity levels. And we find that few products are able to scale. So really engaging with that end user is critically important. One thing that I think is very beneficial in this market is the fact that we have digital public goods that we can leverage. This makes it very cost efficient to adapt as well as customize those goods to the local context. So that is very important, and I think a huge value add to the digital health community. One challenge I will say is that there is often a misconception that these goods are free. And so really becoming more clear about the total cost of ownership will be important for sustainability.
Thank you, Tara. I wish we had the gift of time, but I do want to explore a little bit from some of the other panelists and from our keynote address. So if time allows, we'll invite additional comments to some of these questions. So I'll move to Kanishka. I know you've mentioned how Living Goods is really advocating for the utility of open source communities, and certainly other panelists have spoken to this as well, in order for us to really build sustainable digital public goods. Can you speak briefly to some additional successes and challenges of this approach that, that you have seen in your experiences, but also through Living Goods?
Of course, absolutely, Wambui. This is a very, very good question again. And before I answer the question, let me also, share our journey. We have been, we have been a CHT early adopter for a very, very long time. And as by virtue of that engagement, we have been contributing to the establishment and the evolution of CHT as an established community health digital good. We totally believe in the power and the potential of digital public goods because these not only enable collective learning, but as Tara referred to, these also provide a cost-effective way. Of course, not free. That's a misnomer. We need to counter more strongly. But it is surely a cost-effective way, to handle some of these challenges and implement effective interventions in a timely manner. There is no need to reinvent every single time when we try and address some of these complex public health problems on the ground, and which is where the concept of digital public goods becomes so very relevant in the world we are living in. Some of the successes, of course, all our programs have been a huge learning and a huge success for us. Of course, sometimes we have had to go back to the drawing board and, see what has not worked in terms of our implementation, in terms of our design and development. But I would still call it a success because it has enabled us to move forward. We have a very large team, an in-house technology team established within LG, who continues to work with our program teams and develop newer solutions on the CHT platform. Sorry. Coming to the challenges, I think, also, sorry, on the successes, before I close the successes, but I think the success of digital public goods is not just having digital tools in the hands of CSWs or the users. I think the success lies in achieving the programmatic objectives and achieving, how many lives were saved. And the RCTs which we have carried out in our learning sites, the RCTs which have been carried out have been very promising. Really, across the last 4-5 years, 2 RCTs have been carried out, and the proof is there that these interventions have worked. So there have been And that is how we would want to measure success, whether we have been successful with the digital public good movement. On the challenges side, of course, I think the biggest challenge for us and the digital public good environment is the Apples and the Googles of the world who technology looks so simple, for everyone to adopt. Technology is a more complex, ecosystem to handle, and which is where the challenges for this entire movement of digital public goods comes in, because while the technology on the other side keeps on evolving so fast, I think the challenge for these digital public goods is to keep up with that, pace, to keep up with the increasingly complex programmatic requirements which keep on coming up. And of course, it needs investment, it needs time, and unfortunately, in a lot of moments, that is not available in the sufficient amount, I think, and that kind of hampers and hinders the adoption at moments. But all of us are working together to find the workaround and doing the right thing to push through. But yeah, I think on the challenges side, it's the evolving tech landscape, which is a challenge for all of us to handle.
Sure,
Yeah,
sure.
thanks.
Thank you. And I think, sort of somewhat related to that, Dr. Sitine, you shared the strategy and approach for community-based healthcare delivery. The total cost of ownership, especially start to think about how you're centralizing it from all these disparate implementations that you had described in your presentation. Could you briefly describe one or two important factors that the government of Kenya has considered as you start to think about the cost of ownership, and how open source and community-led solutions have addressed some of these costs?
Well, thank you, Chair. I think I would like to first allude to something that I think has also been mentioned. The fact that for the digital solutions to survive in a place like in Kenya, first, ownership by the government is paramount. If the government does not own, when the partner who supported the development goes, the solution also goes with the person. And worse still, it goes with the data. And that is the worst thing that can happen. But in our case, we partnered very closely with the Living Goods and other players to develop this system. So we've been in it as we move along. But also the local community has been involved. Although we've been trying to use modules that are already up there, the involvement of the local community has improved the processes, because more often than not, we find solutions which are dumped in a particular place from other places. And those solutions have been developed using some processes which are alien to the place where they're dumped. And sometimes they may have been processes which somebody thought through in their mind and thought that this is the best way to work. In that case, then when you reach the particular country like Kenya, the bottom line is that the processes of the country have to change to conform. And that again creates another barrier in terms of acceptability, particularly when you are dealing with people who are not fully funded. Our case is a little bit, perhaps a bit complicated in the sense that when we talk about the community health information system, we are looking at that as one component amongst the bigger picture. Our picture is huge. In fact, we call it a digital health platform. The community is just one level, and we are using that to feed into level one, from level 1 to level 2, because level 1 is the community. Level 2 will feed into 3 and 4, as I said, because that's where the hinge for the primary healthcare is, at the hub of the sub-county hospital, and then above that. So we are looking at all levels of service delivery. And our thinking at the moment is that we should be able to map that individual whose data has been captured, so much so that if that person moves from wherever they are and they go to another county or another district or another place for service, that particular county or district may be demonstrating favorable outcomes, but they don't own that person. That person comes from a particular place. So it will also be used to map, if I may call it so. I think the technology in GIS has come on board. So we can be able to map individuals from where they come from and not where they are getting the services, because if you are at level 6, then it doesn't mean that you belong at that level, but you come from a particular constituency or much, much lower. So when the government picked up this and partnered to work with Living Goods and these other partners, we are seeing a progressive increment and ownership, not just by the national government, but also by the counties, and more importantly, by the sub-counties and the people who are going to do the job. And these are the employees at that particular level who become the motivators to the lower level, the community volunteers, to encourage them to use the system, and they can be able to demonstrate that in my area, we are doing something good. And by extension, we want to politicize this so that when we make it political and have those heat maps at the local constituency level, then we hold our leaders accountable. And they'll also be seeing the graph as it changes, the pictures as they migrate from red to amber to green, and it makes them ask questions. And by extension, that will also make the interest not just go up, but also the resources that are being mobilized by these people, because they're the policy holders. They're the people who hold the purse strings. So if they feel that this is good, it is good. Over.
Sure. Thank you, Dr. Sitini. So Krishna, Dr. Krishna, we'll close with you in about a minute or less. Can you help us? This is a conversation about inclusive innovation. Certainly, we've heard a lot today around how we should be doing it and who should be convened and who should be a part of this and the best way to build. But how do we think about this from a sustaining perspective? How do we think about this in the context of building relevance? How are you and MEDIC and partners thinking about this? And we have about 30 seconds now.
Okay, so first, really breaking through the constant of vertical and 3 to 5 year project funding cycles, which brings about instability. Second, I think, really complementing human-centered design in everything we do and optimizing for longitudinal continuums of care, as Dr. Sitine mentioned. And third, durable digital goods take time and patience to build. And this means investing in technical partners and HCD capacity in country. Appropriate educational opportunities and social business investment and growth opportunities are urgently needed. Thank you.
Fantastic, thank you. I want to say thank you to the panelists. Clearly, this is the beginning of a conversation and a convening that I think needs to happen more regularly. And so my thanks to you. I'll now pass on to John Fairhurst, the head of private sector engagement at the Global Fund to fight AIDS, TB, and malaria for closing remarks, sort of bringing this together. John, over to you.
Thank you, Wamburi, and obviously Dr. Sitine and the panelists for giving me a completely impossible job to summarize the richness of that conversation. But in a couple of minutes, a few thoughts. I mean, I think it's really clear that the potential of digital is obvious. This is not about whether this has a fundamental impact on the ability to deliver health. We know, we've had examples from Kanishka and Krishna about that. Really clearly, this is about how quickly we get there, how effectively we scale, and how effectively we sustain the programs. And I think those are the questions that come out really clearly. I think we heard about the importance of digitally enabled community health workers. From everybody, they're the backbone to our success here. The importance of global goods, but accessible global goods that people can take and adapt, and link with that the power of local capacity in order to do that, to evolve and develop systems, locally driven innovation. And then, as Dr. Sitine very powerfully said, the importance of local ownership and leadership, which he's demonstrated really clearly, is fundamental. And then, the thing that Tara mentioned that stood out really clearly to me is this important. We need to break this cycle of fragmentation. If we don't break the cycle of fragmentation and we don't build, and we don't break the sort of imposition of solutions, then we won't be successful in bringing scaled, efficient solutions to what we need. So building this virtuous cycle is about local capacity. It's about building platforms for scale. It's about human-centered design. And of course, the last thing I think I would say is this will only be successful if it reduces inequity. If we don't design this with full access and the desire to bring equity to people's access to digital, the use of digital, and obviously, of course, health at the core of this, we won't be successful. So making sure people, civil society, are at the center of the design of this is really central. So I didn't do anything justice in that, but hopefully I picked up a few of the key points, and thank you for having me close this, and thank you again for everyone for giving such a rich conversation to try and summarize.
Thank you, John. Thank you, Dr. Sitane, Tara, Kanishka, Dr. Jaffa, Dr. Leslie, to the partners that have made this possible. Like I said, hopefully the first of many convenings. I certainly feel more informed on the key enablers for inclusive innovation in building and sustaining public health infrastructure using digital global goods. We thank you all, and we wish you a good afternoon, morning, or good evening. Thank you very much.
Thank you.
Thank you and bye.
Thank you and bye-bye. And I think there's a link was posted for
Thank
anyone that might be
you.
interested in the slides that were presented. It's in the chat from Emma. Okay, thank you for joining us, and have a great rest of the day.
Thank you.
Thank you.